You are about to go under anesthesia. Maybe it is tomorrow, maybe it is next week, and right now, you are terrified. You want to know what is really going to happen to you, not the sanitized version they give you in pre-op, the truth. What actually happens to your brain, your body, your consciousness when they put you under. And I am going to tell you everything, because you deserve to know. I'm Dr. Dan Carter, and over the course of my career, I have watched this process unfold thousands of times. I have seen people lose consciousness in seconds and come back hours later with no memory of anything in between. I have seen things go perfectly, and I have seen things go wrong. What I am about to share with you is what really happens in that operating room, the science, the risks, the things the medical team does not always tell you because they do not want to scare you. But you are here because you want the truth. So let's talk about it. First, let's address the question everyone is thinking but afraid to ask. Will I wake up during surgery? It is called anesthesia awareness, and yes, it happens. But before you panic, let me give you the real numbers. It occurs in roughly 1 to 2 cases per 1,000. That is 0.1 to 0.2%. Your chance of being struck by lightning in your lifetime is higher, but it does happen, and when it does, it is traumatic. Patients describe being paralyzed but conscious, hearing conversations, feeling sensations, unable to signal that they are awake. There are protocols in place to prevent this. Monitors that track brain activity, medications dosed with precision. But medicine is not perfect, and you should know that. Now, here is what actually happens when you go under. You are lying on the operating table. The surgical lights are bright. The room is cold, always cold, because bacteria grow slower in cold environments. The anesthesiologist is standing next to you. They have introduced themselves. They have checked your chart. They know your medical history, your allergies, your fears. And they are about to do something that frankly borders on miraculous and terrifying at the same time. They are going to turn off your consciousness. Think about that for a moment. Consciousness. The thing that makes you, you. The awareness of existing. They are going to chemically eliminate it. And then, when the surgeons are done cutting into your body and repairing what needs to be repaired, they are going to bring it back. Like flipping a switch off and then on again. Except it is not a switch. It is a carefully orchestrated chemical manipulation of your brain. Here's what happens step by step. First, pre-medication. Usually something like midazolam, a benzodiazepine. It does 2 things. First, it calms you down, reduces anxiety. Second, and this is the part patients find unsettling, it causes anterograde amnesia. You will not remember what happens after it is administered. You might be talking to the nurses, joking, signing additional consent forms, and later you will have zero memory of any of it. Your brain simply stops forming new memories. Then comes induction. You are told to take some deep breaths of pure oxygen. This is called pre-oxygenation, because in about 60 seconds you are going to stop breathing on your own, and the anesthesiologist needs your blood saturated with oxygen to buy time to secure your airway. You breathe the oxygen, and then propofol is injected into your IV. Propofol is white, looks like milk. Medical teams sometimes call it milk of amnesia. It burns going in. Patients often say their arm feels like it is on fire. That is normal. It is not damaging anything. It simply activates pain receptors as it travels up your vein. But you will not care about the burning for long, because within seconds, you are gone. And when I say gone, I mean gone. Propofol works faster than almost any drug in the medical arsenal. 8 to 10 seconds from injection to unconsciousness. Your eyes roll back, your body goes limp, your breathing stops. You are, for all practical purposes, in a state very close to death. Your consciousness has been eliminated. And now it is the anesthesiologist's job to keep you alive. Here is where it gets interesting. We do not actually know how anesthesia works. We know what it does. We can see the effects on brain scans. But the mechanism, the actual process by which these drugs eliminate consciousness, that is still a mystery. There are theories. The prevailing one is that it disrupts communication between different parts of your brain. The prefrontal cortex, which handles awareness and decision-making, gets disconnected from other regions. Your brain stops integrating information. And without that integration, there is no consciousness, just isolated neural activity going nowhere. But back to you on the table. You have stopped breathing, so the anesthesiologist is breathing for you. A mask is placed over your face. The bag is squeezed manually to push oxygen into your lungs. Your chest rises and falls. The monitors are tracking everything: your oxygen saturation, your heart rate, your blood pressure. All of these begin changing the moment you lose consciousness. Now, the airway needs to be secured. You are going to be unconscious for a while, and manual ventilation cannot continue for the entire duration. So the anesthesiologist performs intubation. Your mouth is opened. A laryngoscope, essentially a curved metal blade with a light, is used to visualize your vocal cords. A plastic tube is threaded down your trachea into your windpipe. This tube connects to a ventilator, a machine that will breathe for you. Intubation is a skill. It requires years of practice, and it is not always straightforward. Some people have difficult airways, anatomy that makes it hard to see the vocal cords. When that happens, there are backup plans: video laryngoscopes, alternative devices. In extreme cases, a surgical airway can be created, but most of the time it goes smoothly. The tube goes in. A small balloon on the end is inflated to hold it in place. Placement is confirmed by listening to the lungs, and now you are connected to the ventilator. But you are not just unconscious, you have also been paralyzed. A neuromuscular blocking agent has been administered, usually rocuronium or succinylcholine. These drugs block the signal between your nerves and your muscles. Your brain can send all the signals it wants. Your muscles will not respond. This serves two purposes. First, it makes intubation easier because the jaw and vocal cords relax. Second, it prevents you from moving during surgery. Even unconscious people can have reflexive movements. That cannot happen when a surgeon is cutting into you. So now you are unconscious, paralyzed, and being ventilated by a machine. But the anesthesiologist's job is not done. Not even close. Keeping you unconscious requires constant, unbroken attention. What is being used is called a balanced anesthetic, usually a combination of inhaled anesthetic gas, like sevoflurane, and intravenous medications. These are adjusted continuously based on what is happening in the surgery and how your body is responding. Your blood pressure drops during surgery. That is normal. Anesthesia causes vasodilation. Your blood vessels relax, blood pools in your extremities, your heart does not have to work as hard, and pressure falls. If it drops too much, vasopressors are administered to bring it back up. If your heart rate gets too slow, atropine. Too fast, beta blockers. The anesthesiologist is constantly making micro-adjustments to keep your vital signs within an acceptable range. And here is something most people do not realize. They are not in the operating room doing other things. They are not checking their phone or chatting. Their entire focus is on you. They are monitoring dozens of parameters simultaneously: your oxygen levels, your carbon dioxide levels, your breathing pressures, your heart rhythm, your temperature, the depth of your anesthesia, listening to your lungs, watching your chest rise and fall, checking your pupils, feeling your skin temperature. All of this tells them how you are doing. The surgery proceeds. The surgeon is doing their work, and you are somewhere else, not asleep, not dreaming, just absent. Studies have shown that under proper anesthesia, the brain does not generate dreams. There is not enough activity. You are not asleep in the normal sense. Sleep is an active process. Your brain cycles through different stages. Dreams occur during REM sleep. But under anesthesia, none of that happens. Your brain activity is suppressed, dampened. There is nothing to remember because nothing is being experienced. Except when something goes wrong. Sometimes, rarely, the anesthesia is not deep enough. The patient starts to lighten. There are signs: tearing, increased heart rate, subtle movement. If the paralytic is partially worn off, a response is immediate. The anesthetic is deepened. But occasionally, in that brief window, patients can have experiences. They hear things, feel things, and because they cannot move or communicate, it is terrifying. This is anesthesia awareness, and it is precisely why brain monitoring exists. EEG-based systems that track the electrical activity in your brain and indicate how deep the anesthesia truly is. But let's talk about the moment that scares people the most: waking up. The surgery is finishing, the surgeon is closing, and it is time to bring you back. The anesthetic gases are stopped, the intravenous medications are reduced, the body is allowed to metabolize what is already circulating. The drugs start to wear off. Brain activity begins to increase. You are transitioning from that suppressed state back toward consciousness. But you are still paralyzed, still intubated. This is a critical window. You need to wake up enough to breathe on your own, but the breathing tube cannot be removed until your protective airway reflexes have returned. If it comes out too early, you could aspirate. Stomach contents could enter your lungs. So the anesthesiologist waits, watching for signs you are waking up. Movement, response to verbal commands. Squeeze my hand. Open your eyes. Take a deep breath. When those signs appear, when there is confidence that you can protect your airway and breathe adequately, the paralytic is reversed. Sugammadex or neostigmine is administered. These drugs counteract the neuromuscular blockade. Your muscles start working again. You start breathing on your own. The ventilator is still supporting you, but your own respiratory effort is visible. And then the tube is removed. The balloon is deflated. The tube is pulled from your trachea. You cough. You gag. This is normal. You might not remember it. That is the residual amnesia from the medications, but it happens. And in those first few moments after the tube comes out, the anesthesiologist is still watching you closely, making sure you are breathing adequately, making sure your oxygen levels stay up, making sure you are safe. You are conscious now, sort of. You are in what is called emergence, that twilight state between unconsciousness and full awareness. You might be confused, agitated. Some patients emerge fighting, thrashing. It is called emergence delirium. Others are calm, peaceful. Everyone is different. But you are breathing on your own. Your heart is beating on its own. You have been brought back. You are moved to recovery. The PACU, post-anesthesia care unit. Nurses are monitoring you. You are still getting supplemental oxygen, still connected to monitors tracking your blood pressure, heart rate, oxygen saturation. And slowly, over the next hour or two, you wake up fully. The amnesia wears off. You become oriented. You remember your name, where you are, what happened. But here is something that does not get discussed enough. What you just experienced was profound. Your consciousness was eliminated. Your body was paralyzed. Your most basic life functions, breathing, circulation, were taken over by machines and medications. You were cut open. Your organs were manipulated. And then you were brought back. You went somewhere very close to death and returned. And for most people, there is no memory of it. Just a blink. One moment you are counting backward, the next you are waking up in recovery. But that absence, that gap in your conscious experience, some people find it deeply disturbing. Where were you? What happens to consciousness when it is turned off? Does it go somewhere, or does it simply cease to exist? These are philosophical questions as much as medical ones, and no one can fully answer them. The brain scans can be read, the neural activity can be measured. But what happens to you? To your subjective experience, to the thing that makes you aware you exist, that remains unknown. Some patients report near-death experiences, especially those who have had complications. Cardiac arrest under anesthesia, clinical death. They describe seeing things, meeting people who have passed, feeling an overwhelming peace, moving through tunnels of light. Skeptics say it is brain hypoxia, lack of oxygen causing hallucinations as the brain shuts down. Believers say it is proof of something beyond the physical. Both perspectives exist within the walls of every hospital. I recall hearing about a patient whose heart stopped during what should have been a routine procedure. The team coded him for nearly 7 minutes. Chest compressions, epinephrine, defibrillation. They got him back, and when he woke up, he told the doctors he had been somewhere else, somewhere quiet. He said his late grandmother was there. She smiled at him, told him he still had things left to do, and then he felt himself being pulled back. Was that real? Was it his dying brain constructing comforting images from memory? No one can say with certainty, but he believed it was real, and it changed him. He came back different, less afraid, more certain of something he could not quite put into words. The risks of anesthesia are real. Death under anesthesia is rare but possible. Roughly 1 in every 200,000 to 300,000 cases. Higher if you have significant medical problems, heart disease, lung disease, extreme age. But for healthy people having routine surgery, the risk is incredibly small. You are more likely to die driving to the hospital than from the anesthesia itself. But complications short of death are more common. Allergic reactions, breathing problems, cardiovascular instability, awareness, postoperative nausea and vomiting, sore throat from intubation, confusion and disorientation, especially in elderly patients. These things happen, they are managed, the team is prepared for them, but they are part of the reality of anesthesia. There is a weight that comes with this work, a weight that never goes away and never gets easier. Every case matters. Every patient matters. The anesthesiologist holds your life in their hands for those hours you are under. A mistake can mean death. Insufficient monitoring can mean a catastrophic complication. People ask whether that kind of responsibility ever becomes frightening, whether doubt ever creeps in. And the honest answer is yes. Not in a way that creates incompetence, but in a way that creates vigilance. The day that healthy fear disappears is the day someone should step away from the operating room. Because fear, healthy fear, a deep respect for what is being done, that is what keeps patients safe. So when you go under anesthesia, know this: you are being cared for by someone who understands the magnitude of what they are doing. Someone who trained for years to manage every possible complication. Someone who is going to watch over you with complete focus for the entire procedure. You are not just another case. You are a person, a life, someone's family member, someone's friend. And bringing you safely through surgery and back to consciousness, that is not just a job. For the people in that room, it is a calling. The mystery of consciousness, the power to eliminate it and restore it, the responsibility of holding life and death in balance. That is what happens when you go under anesthesia. And I hope that now, knowing the truth, you can go into surgery with less fear. Not because there is no risk, there is, but because you understand what is happening. Because you know someone is watching over you. Because you know they have done this thousands of times before, and they will bring you back, just like they always do. If you found this explanation valuable, if it helped you understand what really happens in that operating room, leave a comment. Tell me what scared you most about anesthesia. Tell me what you wish you had known before your surgery. And if you are facing a procedure soon, know that it is perfectly okay to ask questions, to tell your anesthesiologist your fears. They want you to feel as safe as possible, because your trust in them, that is something they never take for granted. I'm Dr. Dan Carter. Take care of yourselves. I will see you in the next one.